welcome to the BAXTER Symposium at the 39th Vicenza course on AKI and CRRT. Today we are going to debate organ crosstalk in ICU patient, which is a very actual and important topic. And in light of this, the possible next generation extracorporeal organ support system, what we have defined a few years ago, ECOS, extracorporeal organ support. To speak about this topic, we have two important experts, Marcus Storr from BAXTER Research and Development Department, and we also have Franco Turani from Rome, Italy. I think it's extremely important to combine the research and development of a company together with the clinical application in the daily practice. And Marco Turani is scientific director of the Cardiothoracic Intensive Care European Hospital in Rome. So with no further ado, I would like to ask Marcus to initiate his speech on the new ECCO R device. Extracorporeal CO2 removal is an important, let's say, component of the ECOS system, and presenting the PRISMALUNG will be interesting for the scientific community to better understand how much we can integrate everything in one specific equipment. The idea to have a very much integrated hardware. So Marcus, you're ready to share your screen, I suppose?
I am ready. I hope you can see my screen.
We see it, and please put it in presentation mode. Excellent.
Thank you. Thank you so much, Professor Ronco, for your kind introduction. Good afternoon, everyone. I really appreciate having the opportunity to talk about devices for extracorporeal CO2 removal. Advances in extracorporeal device technology have made selective ECO2 removal a less invasive and a more feasible option than ECMO. And there are several devices clinically available that utilize low blood flow rates. Blood flow rates we typically use in continuous renal replacement therapies. However, many of these devices were historically designed for use as oxygenators for ECMO treatment in the pediatric setting, rather than being optimized for CO2 removal at such low blood flows. And I want to talk in particular about a new ECO2 removal device, the PRISMALUNG Plus. We have developed specifically for CO2 removal. I will first elaborate on important requirements that have to be considered when developing and designing devices for ECO2 removal. I will demonstrate how mathematical models could help to define the specifications and requirements for such devices. And in the second part, I will introduce the PRISMALUNG Plus device, its design, its characteristics. I will particularly share results on CO2 removal performance we have gained using an in vitro test system. PRISMALUNG Plus is a device that can be integrated into a CRRT system, in particular into our Prisma CRRT system, which is able to process a blood flow of up to 450 mL per minute. That means that the device design had to be tailored to operate efficiently at such low blood flow rates. You know that the advantage of this setting is, of course, that we can use smaller catheters than required for ECMO, which reduces the invasiveness of the therapy and also reduces the risk of catheter-related complications. The major advantage of such a system lies, of course, in there is to be handled by any critical care team that is familiar with CRRT systems. An additional design requirement was that the PRISMALUNG Plus not only can be operated on a CRRT monitor, but that it can be also operated in conjunction with continuous renal replacement therapy. Therefore, we had to consider requirements with respect to blood flow resistance, but also regarding the in-series position of the ECCO device relative to the CRRT device. And here on the scheme on the right, you see a setting where the ECCO 2 removal device is positioned in distal position relative to the CRRT filter. But of course, also the proximal position would be conceivable. In such a setting, low ratios of blood volume to membrane surface is of course desirable to reduce the risk associated with large extracorporeal blood volumes, and at the same time provide the required CO2 removal performance. To get an idea of which CO2 removal performance we would need to enable lung protective mechanical ventilation in mild to moderate ARDS patients, and an idea on the preferential series position of the ECCO 2 removal device relative to the CRRT device, we've used predictions we obtained with a multi-compartment mathematical model of CO2 and oxygen biochemistry of acid-base balance and whole body transport, with the inclusion of an ECCO 2 removal device with or without CRRT device. This model was developed and published by Andreasen and Rees and modified and adapted by Ken Leipold. We see here the calculated ECCO 2 removal rates, which are required in patients with ARDS to achieve a PaCO2 of 46 and 40 millimeter mercury, respectively, for various tidal volumes and at mechanical ventilation frequencies of 20.8 and 26 per minute. You see here on the graph that in order to enable an ultraprotective tidal volume of 4 mils per kilogram predicted body weight, ECCO 2 removal rates in the range between 80 to 135 mils per minute are needed. Of course, depending on the target PaCO2 and on the ventilation frequency. So this gives us a first indication on the desired CO2 removal performance we would need for such a device. A modification of the model allowed the modeling of acid-base balance for in-series application of ECCO 2 removal and CVVH devices. And here the calculated PaCO2 and bicarbonate concentrations during a treatment of mechanically ventilated AKI patients with series ECCO 2 removal and CVVH devices shown. So the orange bar indicate the predictions with the ECCO 2 removal device proximal, and the gray bars with the CVVH device proximal position. And as we can see, the calculated data do not differ significantly with the position. This means that the model suggests that the removal of total CO2 is relatively independent of the position of the two devices in series. So the central process in an extracorporeal CO2 removal device is the transport of carbon dioxide from blood across a gas exchange membrane into the sweep gas by diffusion. The driving force for the gas exchange is the partial CO2 pressure gradient between blood and the gas side of the membrane. The transport is inversely proportional to the resistance. So the transport of CO2 is hindered by three main resistances: the gas phase resistance, the membrane resistance, and the blood phase resistance. And this blood phase resistance, which results from the diffusional boundary layer at the blood membrane interface, represents the by far dominating resistance. So therefore, an ideal ECCO removal device has to focus on minimizing the thickness of the diffusional boundary layer. So this can be accomplished by appropriate blood path design and blood flow conditions. And therefore, the device design and the arrangement of the membrane inside the device are of utmost importance, as you can imagine. A coiled construction design, as we see here, where blood is circulated outside hollow fiber membranes, and the membranes are arranged in a double layer cross-laid mats at an angle with respect to the main direction of the blood flow, provides good mixing of the blood and thus efficient CO2 transport across the membrane wall. We see that in this configuration, where the blood is circumferentially distributed at the inlet compartment, the blood is forced partly around and partly along the cylindrical membranes. And depending on the membrane angle with respect to the direction of the blood flow and the membrane diameter, packing density, and so on, such flow pattern can generate a considerable mixing. And as indicated by the blue arrows, the sweep gas flows in the, or the sweep gas or air, as most commonly is used, flows in the capillary lumen on the basis of the countercurrent flow principle. So we have implemented these design principles in the PRISMALUNG Plus device. As a membrane, we use hydrophobic hollow fiber PMP, polymethylpentene, which has a thin, dense outer layer to prevent plasma breakthrough. Despite this very dense layer, PMP membranes are highly efficient in CO2 transport due to the high intrinsic gas permeability of PMP. The membrane surface area in PRISMALUNG Plus is 0.8 square meter. And to prevent protein binding to the membrane via hydrophobic interaction, which could initiate blood coagulation pathways or inflammatory pathways, the PMP membrane in PRISMALUNG Plus is coated with phosphorylcholine. This is a zwitterionic phospholipid. We have characterized extensively our novel PRISMALUNG Plus device with respect to CO2 removal capacity in an in vitro setting. So we investigated the impact of operating conditions such as blood flow, sweep gas flow, or CO2 partial pressure in the blood. You see here the experimental setup we've used. It was a closed loop circuit in which a continuous infusion of CO2 balanced the CO2 removal from the test gas exchanger in steady state conditions. So we used bovine blood in the circuit. You see that the test circuit comprised a central reservoir filled with the blood, as well as two loops. So the control loop had a gas exchanger connected to a CO2 supply, which was used to achieve and adjust the target inlet PCO2 levels. The control loop is connected, or was connected to the test loop via the central reservoir. And in the test loop on the right, the test device was positioned to determine the CO2 removal capacity. So to determine the CO2 removal rate, the test device, the CO2 inlet flow was adjusted to maintain the target PCO2 and to reach steady state conditions. And at steady state conditions, the CO2 removal from the test circuit is exactly balanced by the CO2 addition to the control loop, since we have a closed system. That means that we can determine CO2 removal rate of the test device by measuring the CO2 inflow rate in the loop. So the CO2 feed into the system equals, so to speak, the amount removed from the system. To validate this method, we also determine CO2 removal rate according to the second equation, what you see, which is based on blood gas analysis data. So together with the PRISMALUNG Plus device, we've tested two other ECCO removal devices, which have the same membrane, PMP hollow fiber membranes, but with 0.35 square meter and 1.35 square meter respectively, different total membrane surface area. So the disproportionately high weight and blood volume of the large filter can be explained by the fact that it has an additional heat exchanger inside of the device. In contrast, PRISMALUNG Plus has no heat exchanger, given that a heat exchanger is available with the CRRT machine. So here we see the nonlinear relationship between sweep gas flow, and we used air as sweep gas, and CO2 removal rate. So the test was done with a PRISMALUNG Plus prototype device, and we can see a marked increase in CO2 clearance from a gas flow rate of 0 to 5 liter per minute, reaching a plateau after 10 liter per minute for a device blood flow of 400 mils per minute. So since we saw this plateauing effect, we set the sweep gas flow at 10 liter per minute for the subsequent investigations. So here the CO2 removal rates of the different devices are shown as a function of blood flow at a blood inlet PCO2 of 60 millimeter mercury. And you see for all devices, CO2 removal rates increase with increasing blood flow. The mean CO2 removal rates for the PRISMALUNG Plus device were 60, 65, 86, and 111 mils per minute at blood flow of 200, 300, and 450 mils per minute respectively. The PRISMALUNG Plus and the filter with the largest surface area with 1.35 square meter surface area provided comparable CO2 removal rates. And both had about 50% greater rates than those of the filter with the lowest surface area. So the similarity in CO2 removal performance observed for PRISMALUNG Plus and the much larger filter in terms of surface area can be explained that both membrane area and blood flow govern the rate of CO2 removal. However, at an increase in surface area above a certain threshold, we see limited impact on CO2 removal rate, since then the blood flow limits the CO2 removal rate. So here we see the CO2 removal rates for PRISMALUNG Plus at different inlet PCO2 levels. As expected, removal rates increase with increasing PCO2. And you also see that at the extreme conditions we have selected, blood flow 450 mils per minute and inlet PCO2 of 80 millimeter mercury, a CO2 removal rate of 100, more than 130, I think 133 mils per minute was demonstrated for the PRISMALUNG Plus device. I mentioned that blood flow resistance in such a setting is very important, and we measured the pressure drop on the blood side for the different devices. And we see that the pressure drop was largest for the smallest device, for the 0.35 square meter filter, and lowest for the largest device, suggesting that the difference is likely driven by the membrane area and the blood volume in the device. But the pressure drops values across all three devices were relatively low, with levels of up to 25 millimeter mercury with PRISMALUNG Plus at the blood flow rate of 450 mils per minute. I mentioned the CO2 removal performance was analyzed using this quite simple infusion method, which is based on the measured amount of CO2 we infused into the closed test circuit. Using blood gas analysis, we've checked the validity of this simple method, as you can see here from this linear regression analysis, which compared the two methods. Two methods really yielded very similar results, which really shows or proves the validity of this quite simple test method for CO2 removal. Finally, we've tested the effectiveness of the antithrombogenic membrane coating. I mentioned that we use phosphorycholine as a coating to reduce blood clotting. Therefore, 3 healthy sheep underwent 6-hour treatments without any systemic anticoagulation. So each sheep was treated with 4 different devices, 2 devices with coated membranes and 2 devices with non-coated membranes. And on the right, this time to clotting analysis shows that both coated devices, so one device was coated with phosphorycholine, the other device was coated with heparin, they showed no sign of clotting over the 6-hour treatment, whereas the non-coated devices showed a premature clotting before reaching the 6-hour treatment time for the majority of the treatments. So to summarize, the PRISMALUNG Plus device has a design tailored to specifically remove CO2. The device design, including the fluid path and the dimensional parameters, the design, the selected membrane surface area, and the blood flow volume, allows for optimized CO2 removal at the intended operating blood flows of 200 to 450 mL per minute. We could show that, of course, depending on the operating blood flow and the PCO2, carbon dioxide removal rates of more than 130 mL per minute can be achieved with this device. PRISMALUNG Plus can be used for a standalone therapy, but can also be integrated with other organ support strategies, such as continuous renal replacement therapies. Thank you so much for your attention.
Thank you very much, Marcus. I think this is a very, very important presentation you made, because it makes us understanding for the first time the kinetics of CO2 through the membrane in the circuit of CRRT, and in any case in extracorporeal therapies. Hopefully we will have time for some questions at the end. I would like now to ask my friend Franco Turani to move towards the concept of an integrated platform for ECOS in order to manage different organs that may be dysfunctioning in critical care. As you might remember, many years ago, we proposed the concept of multiple organ support therapy. And indeed, it seems that this is getting through as a dream with the next generation extracorporeal devices. So, Franco, please present your topic.
Oh, thank you very much for your kind invitation in this very, very important meeting. I'm very happy to be here with you and all the people here. And I thank you for your kind invitation, and thank for also Baxter for the possibility to read my lecture here. Okay. Okay. This is my agenda in this my talk. I may speak about the role of the mediator during AKI and ALI. The rationale I use is there is a rationale to use ECOS and MOF. The important relationship between CO2 removal and cytokine, and some clinical experience we show of our center between ECCO, PRISMALUNG, and oXiris, and a new data on PRISMALUNG Plus, some preliminary but very important data, and then I will discuss some conclusion with you. We know that we can say that there is a common form of single organ insufficiency between AKI and ALI, because we have to mention 2 important points. Patients with ALI ARDS have a very high incidence of AKI, between 25 and 60% in mechanical ventilator patients, but very, very important, there is a strong evidence between the use of mechanical ventilation and development of AKI. Then there is a very danger to use mechanical ventilation, and there is important relationship between AKI and mechanical ventilation. Moreover, a crosstalk between the lung and the kidney have important action on the heart. Then this is the beginning of the multi-organ failure, as either cytokine and either induced of apoptosis might decrease dramatically heart function and explain the high mortality you see in ARDS ALI patient with AKI. You know that in this graphic, ARDS with severe trauma and 80% of survival. When there is an oliguric renal failure, your hospital survival is very, very low. Probably either ventilatory support and either organ dysfunction increase. This is a very famous theory of Ronco, increase either pro-inflammatory mediator and anti-inflammatory mediator. This start with endothelial dysfunction and might result in organ failure. We study a lot of pro-inflammatory mediator. Interleukin 6 is very, very studied. This correlates with mortality, with MOF, and with AKI. And it is important experimental study in AKI patient. You see that in experimental model, wild-type mice were compared with mice with interleukin deficient. When these two groups were compared in terms of lung disease, you see that the wild-type mice without interleukin 6 had a better lung function than a wild type, indicating that very important notion that the interleukin 6 contributes to lung injury after AKI. And then probably favoring the rationale to decrease to absorb interleukin 6 during AKI. Other important mediator have been studied, endotoxin, procalcitonin, but you know we have no definitive data on the absorption of this mediator. The same also during COVID-19, there is a similar response as during AKI and MOF, with at your left a pro-inflammatory early phase with hypercoagulation and with a later phase with immunosuppression. Then either from COVID-19 and then from AKI and MOF, probably there is a rationale to use ECOS in MOF. ECOS by block no specific cytokine, then allow endothelial protection and support organ failure. We have a lot of ECOS technique. The most important we have used as continuous venous hemofiltration, venous arterial extracorporeal membrane oxygenator, venous extracorporeal membrane oxygenation, and in our experience we have some data either from PRISMALUNG and PRISMALUNG Plus. All these devices have been used extensively during COVID-19 with some contrast result. You see here have been used a polymyxin, have been used oXiris, have used blood purification with not definitive data during COVID-19. But the open question from this consideration is whether there is a rationale to combine ECOS respiration support and RRT with absorbing membrane to increase mediator clearance. The first response is a very prudent. This work group on acute disease quality initiative 20I work group do not recommend the use of CRRT and hemoabsorption with the sole intention to clear a pro-inflammatory mediator. Some observation on Lancet respiration have observed there may be a negative effect on survival when hemoabsorption is used at the beginning of ECMO. But the question is, what is the effect of hemoabsorption during SCO2 removal? We have a very low data. We can start from the important study of Terragni. He treated two different groups, one of the ARDS net strategy, maintaining the pressure plateau less than 28, and another group with a strategy of ultraprotective ventilation with CO2 removal. And there is an important decrease of interleukin-6, either at plasmatic and at alveolar level, confirming that CO2 removal by decreasing, by achieving protective ventilation might decrease interleukin-6 response. Same data were shown from the group of Salvatore Grosso in Berry, who showed that during low RR CO2 removal, either interleukin-6 and interleukin-8 decreased in the plasma, and also decreased in the bronchoalveolar lavage. Then our hypothesis was to evaluate whether an ecosystem with a CO removal and RRT may modulate also the inflammatory response. We have studied patients with respiratory failure and AKI submitted to CO2 removal and RRT with an absorbing membrane. This is a retrospective observational case series in our hospital in Aurelia, a population with a patient with AKI, more than one, associated to hypercapnic acidosis due to moderate RDS or COPD. Primary outcome was evaluation of safety, feasibility, and efficacy of novel CCO2R combined device, and the protocol in part was the protocol of Gonzalez in blood purification on the Cicero study. We study this patient using the first device, PRISMALUNG BAXTER, with area of 0.35 with membrane coating of polymethyl pentane and heparin. This is the device in the clinic. On your right, you see the oxygenator. And here you see the oxygenator with oXiris membrane you used in our study. You know the oXiris membrane is a 3-layer membrane, then is able to attach absorb endotoxin by polyethylamine, and in his first layer as a acrylonitrile molecule that can absorb cytokine, and then they have a possibility to perform a good dialysis and a good anti-inflammatory action. We studied 12 patients, this is the wage, and the SOFA total was 12 with a very severely ill patient. We studied 10 patients with COPD, 2 patients with mild ARDS, 8 patients were AKI, 10 patients were with invasive ventilation, and 2 with non-invasive ventilation. This is the treatment of the patient. The QB was 250 with 150 of standard deviation. Patient was enrolled 12. We know 1 patient excluded. Treatment time for patient was 72 hours. Number of oxygenator for patient was 1, and a number of dialysis membrane for patient 1 plus 1.5. This is most important data. PCO2 decreased during the study. A pH improved as expected. There was no change of bicarbonate, no change of lactate, no change as expected of PF ratio, a decrease not statistically of PEEP, but a good response to plateau pressure and a good response at T3 of dragging pressure. Interesting, also noradrenaline decreased at T2, and the creatinine also, as expected, decreased from top 2.5 to less than 1.0. Interesting, the clearance of VCO2 was on 60 ml minutes and was correlated with the data of Gattinoni, a study all the experimentally extracorporeal CO2 removal. Interesting, in this patient in which we used also oXiris membrane plus oxygenator, you see there is an statistical decrease also of interleukin-6, confirming the data of Terragni and Grasso, as you have seen before. Importantly, as in Cicero study, there was no major bleeding event, only 2 minor bleeding events, no thrombosis of oxygenator, no pump malfunction, and not membrane thrombosis. And this is very interesting, in spite of membrane is very small, is very surface area, but quite with a quite good result in terms of clinical management. In the last months, we have some experience with PRISMALUNG Plus. You see that the area is more than the PRISMALUNG 1, and also the membrane coating is different because there is a phosphocholine with polymethyl pentane. This is the slide of the oxygenator in the standalone. It is the slide of the oxygenator with the CRRT membrane, with the dialysis membrane. Now we have a number, 5 patient study. Now with the last 2, we are at a 7 patient study. These are the more clinical important data. Now we have the 4 patients with COPD, 1 patient with COVID-19, 1 patient with cardiogenic shock, and 1 patient with septic shock. We use the 4 now standalone, 1 oXiris membrane, 1 ST 150 membrane for the treatment hours of 54 hours plus 21. we have a very few data, but you see that we have an increase of pH as hypothesized by the study, and the important decrease of PCO2. We have not the data for the last patient. Interesting, the CO2 removal clearance was more than 100, was quite different. We have no statistical data from the PRISMALUNG one, the Prisma when a little absorbing surface area. And there was a good stability for the pressure. You see all the pressure during the 24 hour of the study. And you see also, very important, the drop in pressure are very, very stable, are constant, and that this is the sign that the machine and the filter good work, and we have a very important clinical stability, but the problem of coagulation is open to discussion. I have some point to conclude my presentation. We have seen we have many devices, but obviously we have not a lack of definitive data. We think we need to stratificate a patient. For example, COPD different from mild ARDS because there is some physiopathologic problem to treat together the patient. We have seen some change of pro-inflammatory mediator, but we know that are very important also data on anti-inflammatory mediators. A very, very important problem is the anticoagulation strategy. And first, at the end of my discussion, we need obviously a study, randomized clinical trial with a very clear endpoint in a patient very well stratified. Thank you very much for your attention, and thank you very much for your invitation.
Thank you. We have only 2 minutes left, so I will use these 2 minutes. One question to Marcus, one to Franco. To Marcus first, there is a lot of debate whether PRISMALUNG and in general extracorporeal CO2 removal can be used at blood flows in the range of 400 mL per minute. This is the real integration when you try to do CRRT and so on. So according to your experiments, is it still efficient at 400 mL per minute?
In terms of CO2 removal capacity, of course, it is efficient. You have seen, of course, there is a dependency of CO2 removal with blood flow. Increasing blood flow increases CO2 removal. But we have seen that even with blood flows of 300 mL per minute, we have exchange rates or CO2 clearance rates in the range of close to 100 mL per minute, which is quite efficient, assuming that we have in total some 200 mL per minute CO2 removal generated in the patient.
So this is very important message. It can be used not necessarily with very high blood flows. Absolutely. Franco, very quickly, which one is the patient, the typical patient where you want to apply this?
Now we have a large experience with COPD patient in clinical, so in deterioration with the PaCO2 very high, but with a stability of cardiovascular system, is not in coma, and we have rapidly, we can see a very clinical improvement with the patient without intubation.
So this acute on chronic situation.
Yes.
What about just acute patients?
This is acute is very interesting, but we need to improve mechanical ventilation to achieve a very protective ventilation in this patient, and to choose the right dosage of anticoagulation. That is very important problem for us. Then we choose to study the thromboelastography and choose the right dosage of heparin in the case.
Does extracorporeal CO2 removal allow to avoid to intubate some patients?
I think so. In some patient may avoid intubation.
And in those intubated, ultraprotective ventilation is still possible.
It's still possible, yes.
So thank you very much to everybody to join this symposium. I think it was rich of information, and we can follow up with the scientific program of the 39th Vicenza course on AKI and CRRT. Thanks for attending.
Thank you very much. Thank you very much.